This is part of a respiratory package, and so Michelle Chatwin is speaking after me on some physiotherapy aspects, which I hope will be complementary, answering some of the questions you asked. And then later on, Debbie Field is going to speak about advanced respiratory care for people with severe respiratory problems. I'm going to give an update, and I'm not going to go over things we've discussed in the past and established evidence, but talk a little bit about what's new. And I'm going to cover some of the questions that were sent to us by Anne and Wendy that you raised prior to this meeting. I'm going to talk about some new guidelines, which may be on other conditions, but there's a good crossover and they're relevant to myotubular myopathy, centronuclear myopathy, a little bit on some new techniques, respiratory techniques, and improvements on current ones. And then just a few minutes, which I think are on a very important area, which is as new treatments come along, gene therapy, a range of other new treatments, how we start to incorporate these new treatments in our management plans, bearing in mind that some of the improvements will be incremental, and there'll be a range of effects of those treatments. Some, we hope, very significant effects and improvements, but others will be moving the situation on somewhat, but people will still have a degree of a respiratory problem. And then I'll talk a little bit about preventative respiratory care. So some of the questions that were raised on how might you improve lung capacity, what methods or exercises can be used to improve lung function, and there was also a question on how you could improve chest wall development for children who have a characteristic sort of scooped out chest wall appearance, and Michelle will talk about that. There was a question on heart rate and what's normal during sleep, and I'll mention a little bit about sleep physiology, what's normal and what to look out for. And then, to some degree, the evidence that's available on physical activity. And then there was another question on what tests are mandatory and how often should they be performed. So, some general points, I think, and that is for everyone, fitness and absolutely maximising a level of fitness, not just for the respiratory muscles, but for all muscle strength is important. And I think a decent amount of evidence that as a child is growing, the greater the peak vital capacity you can get to, the better the overall performance long term. And so we're in the process of, as the child grows, absolutely maximising their lung function until you reach a peak, after which there may be a fall off in lung function. Exercise is usually always good for muscles, but there are certain situations where one should be cautious, one should avoid fatiguing the muscle. I'm going to come back to some of the sort of important areas to watch for. And if someone has already developed ventilatory failure, that is their carbon dioxide level is raised during the day or at night, then that's evidence that the muscles are really under some strain, and one needs to be cautious about how much exercise one submits them to. But that doesn't mean that some form of exercise isn't important even in that situation, and stretching, passive resistance exercises, maintaining mobility, maintaining posture, as we have postural muscles as well as breathing muscles and limb muscles, is always helpful and it's something that should be part of everyday activity. There's also been some interesting information that came through from studies of exercise in children with a range of respiratory disorders, so not just neuromuscular disorders, but a whole range of respiratory disorders, where they did specific exercises on exercise bikes, on treadmills and so on. And they came to a very interesting and I think common sense conclusion that in many circumstances, just doing general type of exercises such as swimming, such as running, such as being active in the playground and so forth, can be as valuable as doing really boring specific exercises and even specific respiratory muscle training, because if you're swimming, if you're active, you're using your respiratory muscles, and it's actually quite boring sitting on an incentive spirometer or some of the respiratory muscle training devices. That's a bore to do, but swimming is much more fun. There are specific circumstances where using these respiratory muscle training devices may be helpful, perhaps during recovery from an infection. And as you'll see, the research in this area is really limited and it's difficult to interpret because a lot of the work has been done in very mixed groups of patients. So there are not big studies with large numbers of patients with myotubular myopathy, putting them through a variety of exercise programs. And just as an example, when you want to know how effective a particular intervention is, you go back to the literature and you look for meta-analysis, you look for systematic reviews. This is a systematic review on exercise in patients with neuromuscular disorders, but the real problem you see here is that it's really mixed groups of patients. There are some with myotubular myopathy, a whole range of different diagnoses. They're also doing different types of training, a circle ergometer, walking training at various levels of peak exercise level, and also for different periods of time and looking at different sorts of endpoints. So trying to draw conclusions from these very mixed bunches of patients doing very mixed sorts of training programs over relatively short periods of time is difficult. The one thing you always have to do is avoid doing harm. And this was a Cochrane review, very nice reviews, usually assembling all the evidence available, just trying to exclude doing harm from strength training and aerobic training. That's being on an exercise bike, walking, swimming, and so forth. And it showed that, again, with people with a range of conditions, even inflammatory conditions, that there was very little evidence of harm, that you weren't doing harm, but that further research, as they always say, was needed to demonstrate benefit. And then another very interesting, I think, systematic review, because this was looking at devices that can measure habitual physical activity, because for all the trials, and we talked about burdens of trials and having to go to centres and having your blood tests done and your measures of, say, respiratory muscle function with breathing tests and so forth. They're not telling us much about what people do from day to day, and we now have a lot of activity monitors, activity apps, which can tell people's general level of activity, and I think these will become increasingly useful in future because they're telling us what happens in the real world. Is someone more active as a result of a new trial drug? They're able to move their arms more. If they're in a wheelchair, for example, are they able to walk more? They're generally more active. And I think one of the futures in assessment, even for trials of new drugs, will be in understanding what happens with everyday physical activity and using apps. I'm sorry about the quality of this slide because I photographed it because it's difficult to cut and paste, but this was just summarising the types of exercise. And you can see essentially what we've got here is endurance conditioning, these sort of exercises, building strength and muscle mass. And by this I don't mean all those sort of grunting Olympic weightlifters who I always think are going to drop the weights on their toes, but luckily they don't. So we're talking about simple weight training and working against resistance, which anyone can do. Then activities increasing agility and then flexibility, which again is suitable for people with quite marked muscle weakness, and we can come back to that. I also suggest that because of the huge variety, so we mentioned a mixed group of patients in many of these exercise programs. There's also, of course, a huge mixture of people with myotubular myopathy just in this room, and therefore, again, it points to the real difficulty of doing trials because each of you are individual, each have a particular extent of the condition, muscles are affected in different ways, and so that really speaks to everyone having a personalised plan that checks. We want to avoid fatigue. We want to take particular care in individuals with cardiomyopathy, but that doesn't mean that they don't exercise. We want to protect them from arrhythmias and so forth. Someone asked about heart rates. We don't want to push the heart rate too high, but you do have to increase it to get a training effect. So I think you certainly wouldn't want to go over 150 heart rate per minute. Exercise that brings on nausea or breathlessness that doesn't recover within a few minutes. And I'm thinking about 3 or 4 minutes. So if you're pushing yourself so far that the effort causes you to be breathless, for you to have pain in the chest, for you to feel sick, then you've gone too far and you need to come back. There's a nice article in the Muscular Dystrophy Association of the US is pamphlet, a booklet called Quest that comes out several times a year when they discuss different sorts of exercise in patients with a whole range of neuromuscular conditions, including tubular myopathy, and that's available on their website. And then finally, I'd like to put in a particular plea for breathing control. There's your exercise capacity, but there's also being able to control your breathing, to pace yourself. I personally think singing and playing musical instruments can be extremely helpful there, and obviously great fun. So moving on swiftly to the question about physiology during sleep. In fact, we all underbreathe during sleep because we all rest our breathing muscles. And heart rate, we're resting our heart as well, so heart rate drops. Usually I would expect the heart rate to be above 50 per minute during sleep. In fact, I had a 24-hour tape myself and my heart rate went down to 39 per minute overnight. I'm still here. Although it would be hilarious if I dropped dead next week, because you won't believe anything I've said. But the things to watch for are in someone, you're worried about your child, watching them asleep, is struggling to breathe, extreme restlessness, I don't mean in this hot weather. I also think almost imperceptible breathing, so quite profound hypoventilation. But often the symptoms are more marked the next day, so being extra sluggish during the day, not being able to concentrate at school, and for older children to ask about headaches. Just briefly too, to talk about, this is a standards of care document. It was actually formulated, it's just been published in the last 6 or 9 months or so. This is standards of care for respiratory management of spinal muscular atrophy. Well, you might say I don't care about that, but the rationale and the understanding behind it is entirely translatable, I think, to tubular myopathy. And this is the kind of treatment algorithm or respiratory assessment that we go through, looking at lung function, coughability, which I think Michelle will talk about, understanding respiratory muscle strength, chest wall shape, swallowing function, and then we need to understand whether there is a problem with underbreathing during sleep that is progressing over time, because you start to see this underbreathing during sleep, this nocturnal hypoventilation, before you see problems with low oxygen level and high carbon dioxide level during the day. Now, I don't intend to go through this in detail because there's obviously too much on the slide, but these are how consensus documents are generated. And one of the problems we always face is this level of evidence is D, so it's sort of consensus decided decisions as opposed to randomized controlled trials, but a lot of evidence from that consensus to understand that sleep studies are fairly important, clinical observation is important, a whole host of things, including preventative measures such as vaccinations. Now, again, this is standards of care document for spinal muscular atrophy, but this is a slide that's relevant to the severely affected type 1 SMA children, and there's a lot of sort of I think cross-understanding between those patients and those with, say, infants with severe X-linked tubular myopathy, and at that age, in a profoundly affected baby, a weak baby, then we would be interested in doing a respiratory assessment every 3 to 6 months initially, and then being guided by how that child is progressing. For a less severely affected child, then we would want to monitor them, see them every 6 months or every 12 months to assess how they're progressing, and do a sleep study perhaps every 12 months. And then there's some more guidelines, and you can go to that document to advise what's appropriate for in-hospital acute care if someone is admitted with a chest infection. Again, I won't go into details there. Now, Michelle is going to talk about acute use of mechanical insufflation, exsufflation. These are the cough assist devices that can be used to help individuals who have a weak cough, and there's been some nice guidelines published there, which I think are going to be helpful for the management of a whole range of neuromuscular conditions. Something else you may come across if you go into hospital or someone in your family goes into hospital is this newish treatment called high-flow oxygen therapy or high-flow nasal cannula therapy. Sometimes it's also called Optiflow or Airvo. Now, this is delivered through some small nasal cannulae, and it's different to high-flow ordinary oxygen therapy, which you may well know that we advise against because giving too much oxygen in some circumstances can be very dangerous and provoke ventilatory failure. This new flow treatment is humidified, which can be extremely helpful in chest infections, helping break up phlegm and help the child or adult clear the secretions. And we are tending to use this in some patients in particular circumstances. In acute chest infections, it can be used alongside non-invasive ventilation. So the person might be on non-invasive ventilation for periods during the day and then come off onto the airvo treatment, this high-flow treatment, which may be easier for them to eat on that, and then go back on the ventilator. So it might be a combination approach. But really, crucially, we need to monitor them very carefully because we need to ensure that we're not provoking worse problems with ventilatory failure, so close monitoring is required. And there isn't an evidence base for this yet in chronic ventilation, hypoventilation at night. But I think this is something we're seeing more and more used acutely in hospitals, often in a high dependency unit or perhaps on a specialist respiratory ward to help someone recover from a chest infection. The reason why it's different to uncontrolled oxygen therapy is that it does other things too. So because of the high flow, it's actually washing out CO2. It's washing out the dead space, which is the whole of the upper airway that doesn't take part in gas exchange. Because of the high flow too, it has a positive pressure effect. It's a little bit like CPAP or a PEEP effect, and so that is helping splint the airway open and actually reducing the work of breathing. And then the high level of humidification, as I mentioned, is helpful to break up tenacious secretions and help with physiotherapy. And so it's having quite a lot of interesting and helpful physiological functions, which makes it much more effective and actually safer than using uncontrolled ordinary high-flow oxygen therapy. But I stress it needs to be carefully monitored. Now, not everyone needs non-invasive ventilation. That's individuals who have developed quite significant problems with their respiratory muscles and chest wall function. But if you do use non-invasive ventilation, you need some kind of interface and like a mask. And sadly, we can sometimes see these really troublesome pressure sores from the mask. And this young man had a mask kept on for about 5 days in a row before it was taken away. I'm glad to say that there are new trials now, so new piece of work looking at understanding the pressure distribution from these interfaces. And to cut a long story short, that I hope will enable better design of masks in future, because we have these nice sort of meteorological maps of where the pressure is extreme in the red areas and then lower pressure. So we can design masks better, but we can also, and this was a trial helping staff and parents and carers fit a mask so that it's not causing undue pressure over particular pressure areas, bridge of the nose, and beneath the nose as well. So that's an area of improvement. And then I mentioned about trying to understand the impact of new therapies and how that in turn will influence the rest of the respiratory care, the rest of the care of the child or adult. And we're feeling our way in other conditions at the moment. And this is nusinersen, a treatment for SMA, and in SMA1 children, it is having a significant effect in these trials at any rate, a significant effect on survival, ventilator-free survival. So there is a longer time before these infants require ventilatory support, but we still have to, this was over a limited period of time of the trial, you can see over 56 weeks, so a year. What happens at 2 years? What happens at 3 years? So we have to understand the impacts of these treatments on the natural history, and while we may delay the time to require ventilation, does that mean we've delayed it forever, or does it mean that the child will need it at 2 or 3 years or more? And this is another example of potential therapeutic targets. This happens to be in Duchenne muscular dystrophy, but it reminds me very much of tubular myopathy, because there's all sorts of, there'll be gene replacement therapy, there'll be myostatins, there'll be modulation of gene function. And so this is something we see in a range of conditions, and at the moment we're involved in using idebenone in patients with Duchenne muscular dystrophy. This slows the rate of respiratory decline in teenage boys with Duchenne muscular dystrophy. It doesn't make their muscles stronger, but it slows the rate of decline. So there's this sort of incremental improvement. And interesting work here is that instead of doing complex measurements of vital capacity, it's been shown that peak flow, so using a simple peak flow meter at home, can generate the peak flow decreases in tandem with the vital capacity, so you can use peak flow, simple measurement at home. You don't have to keep coming up to hospital for the measurements and assessment. And I think that's the way we're moving with assessments for trials, so we can get more home measurements, but they have to be accurate and they have to be reproducible. And then other important endpoints we need to monitor, like bronchopulmonary adverse events, which is a complicated way of saying a chest infection. So this idebenone in Duchenne muscular dystrophy reduces the frequency of chest infections, and I hope we'll start seeing interventions that have that effect in myotubular myopathy as well. We have to be careful about what the endpoints we use, and I think it's helpful if they're everyday endpoints. So where are we going onwards? As I say, I think these considerations will be similar when talking about MTM, and we have to understand the evolving natural history. What is the impact on the natural history? We're particularly interested as well in ensuring that older patients are supported as new therapies are introduced. Some of these new therapies will be introduced in very young children, in infants, but we have many older patients. We have to understand whether the treatments will affect their function. In fact, we're starting to explore idebenone in older patients who are already ventilator dependent. Is it helpful in those patients? Does it affect cardiac function, swallowing, and so forth? And I think we'll see the same in myotubular myopathy. And one good thing is that we have recently been awarded a fellowship in understanding the consequences of growing up with neuromuscular disease, because we're moving into new therapies. Children who are treated with non-invasive ventilation are now living into their teens and their 20s, and they're going to university, and they're going to work, and they're building their lives. And we have to understand the new sort of issues that arise, medical issues that arise. And this is just one study showing how many patients who started on non-invasive ventilation in childhood, and these are the congenital myopathy group here, the triangles, who are actually stabilizing over time and growing older and older, and we need to understand what's happening to their respiratory function and continuing to optimize that. Just a quick last word on preventing chest infections and minimizing consequences. I think some of this we're going to deal with, vaccination. Some of this is pretty obvious as well. Michelle is going to talk about secretion clearance. I think we're clear about organisation of care, having an escalation plan. What are the pointers for GP consults? Debbie will talk about the outreach service as well, so we can deliver care in the home, and then appropriate use of all these interventions. And my last slide is really that we want to optimise preventative care. As I've said at length, we want to understand the impact of new therapies and then integrate them in the current care plans, because I don't think everything is going to change overnight. So this is going to be a new, complicated outcome, but we need to manage it optimally. Increased use of acute and emergency plans, I think, are extremely important. Building skill sets is again part of organisational care, because I'm fully aware that some of you may go to hospitals where they don't have the full panoply of care available, and there are other centres of excellence where there is a kind of different level of care, and that's not fair, and we need to build skill sets in the multidisciplinary team. As I've mentioned, the new approaches such as high flow oxygen therapy. Thank you very much.